This is a video of a robotic parastomal hernia repair with a modified Sugarbaker technique, also known as the Pauli repair. It's a modification where the mesh is placed in a Sugarbaker fashion in the preperitoneal position, which has some theoretical advantages. This is a patient who had an endoleostomy as part of a laparoscopic total colectomy for ulcerative colitis, and she had a very large parastomal hernia in the setting of obesity that was causing a lot of symptoms, including obstructive symptoms, and she needed a somewhat expedited repair. So as you can see, the defect is not huge, but there was a lot of bowel in the defect, and you can see there's a pretty large hernia sac. You can drive the robot in there to visualize it. So what I'm starting to do is just take down the peritoneum. So over to the right to orient you is the falciform ligament going down towards the hernia, marking it out. And I'm actually trying to go a little bit towards the camera side, the patient's left side. You're looking into the right lower quadrant and mobilizing peritoneum to save that. This is actually taking the posterior sheath, so you're entering the retrorectus space. That's the umbilicus with a little belly button hernia that we'll repair as well. But yeah, I'm just dividing the posterior sheath on the patient's right side to get into that nice retrorectus space, which is very useful for many types of hernia repair. You take down the umbilical hernia, and I'm going to go a little ways above the hernia. Ultimately, you'll see we'll place a 15 by 15 centimeter mesh. This video is speeded up to about 4 times speed to make it easy to watch. And you can see the right-sided rectus muscle, and we've preserved that peritoneum for reconstructive purposes if needed. So next step, we're going to mobilize that retrorectus space a bit more, going toward the semilunar line. We go as lateral as we can, but you don't want to disrupt the semilunar line, especially the neurovascular bundles that enter the rectus muscle laterally. So you stay shy of those, and you'll see some of those during this video as well. So we're staying above the level of the stoma right now. And I'm intentionally entering the peritoneum around the level of the stoma as well. We'll, of course, repair that later in the surgery. So that's just transecting the hernia sac, essentially. We'll get as close as we can to the hernia sac and the posterior sheath, and actually intentionally continue to divide that. What you'll see later in the surgery is that internal opening will be lateralized. That's the purpose of the surgery. There's a neurovascular bundle, and actually that might be a little branch of the rectus muscle as well. So now I'm in the suprapubic area, really, and this can be a little confusing, especially in an obese person, but we're trying to get as superficial as possible, actually deep as possible, I should say, toward the peritoneum. And so going through some of that fat. So you can see we're getting closer to the peritoneum. There's the little clear area. And so generally trying to get right onto the peritoneum, that's going to be key to mobilizing that peritoneal flap. If we're confused, you just lift up on the peritoneum and see how close you are. And also, of course, make sure you're not close to bowel at all. So we'll mobilize a little bit more of the peritoneum and posterior sheath next to the ostomy. And we'll go almost circumferential. We'll complete that later. So there's a neurovascular bundle right there I was just pointing out. You don't want to disrupt that. And what we're going to do now is essentially a transversus abdominis release. It's the same steps. We have a separate video on transversus abdominis release, and we're not really trying to release anything, but we do need to be preperitoneal to get as lateral as possible, adjust against peritoneum, and not be bound by the semilunar line. So we're going through that fascial layer. Some people call that the posterior layer of the internal oblique as it splits around the rectus muscle. And as you can see, we found peritoneum right under there. We're far enough caudal that you don't see a great deal of transversus abdominis muscle belly, but these are technically the fibrinous insertions of the transversus muscle. And generally, as you can see, I like to try to mobilize the peritoneum away from the abdominal wall before I do a lot of division. That prevents making holes as you divide that layer. You'll probably make some little holes, and usually that's not a big deal. You can close those fairly easily. But we're going to go as lateral as possible all the way out to essentially where the paracollar gutter used to be in this patient. Made a little hole there, and that's not a big deal. And once you get out to that fatty layer, the dissection is fairly easy. You don't have to worry about making holes in peritoneum. So we're going to keep working kind of behind the ostomy. And we'll start transitioning from caudal to cranial and cranial to caudal until it's done. So there's a subtle layer there. I think that's the equivalent of the semilunar line just above where we're working right now. So this is all just peritoneum. And there's not much posterior sheath down here. There's none really. And keep looking on the underside of that peritoneal flap so we don't get confused. But yeah, that's when we're approaching the semilunar line. We have to do a little bit more division there. And what we're trying to do is make a wide preperitoneal plane here, just like we did more more cranial, and join those two planes together. And that's what we're doing here. We're looking around the ostomy, and you can see the plane we've created above, and we're pulling down, and there's just a little more tissue to go through. We're staying as close as possible to the peritoneum, and now we've made this very large space to create mesh. And so now we just have to finish that division of peritoneum where it's connected to essentially the hernia sac. We'll probably just do that sharply because there's not very much blood supply right there, and I don't want to injure the ostomy. So now we've taken down the peritoneum very, very widely. And so next step I'm going to do now is open the peritoneum moving in a lateral direction. And again, the purpose of this is to make that peritoneal opening more lateral than the abdominal wall opening. So now we'll close the opening, actually we're going to lateralize the stoma first. I think we could have closed the abdominal wall earlier. We'll do that later in this particular surgery. But what I'm trying to do is actually take a bite of mesentery and pull that up against the abdominal wall to essentially lateralize the stoma. And what I try to do in this case is keep the mesentery facing toward the camera, and you can see a little bit of serosa, and I'm going to try to hide that serosa against the abdominal wall so the serosa will not touch mesh. I'm not sure that's a critical step, but when I can do that, I think it adds an element of safety. And now we're going on the caudal side and doing the same thing. And I'm just taking small bites. This is not really structural. It's just to hold the ostomy lateral so that the mesh can essentially make a sandwich mesh conduit and abdominal wall. And this is kind of tricky, especially with an ileostomy, because the mesentery is so medial, so it's a little bit tricky to lateralize. And with for example, a sigmoid colostomy, it's a little bit easier. There's more redundancy in the mesentery. And all of this I'm using locking suture, in this case Stratafix, just because it's easier and I don't have to tie a whole lot of knots. So it's starting to lateralize, but a little bit tricky, as you can tell. And so what I'm doing here is recreating that opening, and this is going to be our lateral opening in the posterior layer, the peritoneum and the posterior sheath. So all of that was exiting the peritoneum much more medial, but we've just lateralized that opening and we're recreating it now. And one thing I didn't include in this video is I did suture the peritoneum to the serosa and the mesentery as well, just to prevent an early herniation of anything around that. So we've got a large space. You can see that that ruler is 15 centimeters, so we can use a 15 by 15 centimeter mesh in that space. But first we have to close this fascial defect, which we could have done earlier in the surgery. In this case, we're using number 1 Stratafix symmetric, a very strong suture. We're going to make it just snug. We can see everything really nicely, and we'll take several bites to do this. We'll run it in both directions for added strength. So I was a little bit unhappy with how lateralized the, especially the mesentery was, so I took a few more bites to try to do that, and in addition it'll cover that little bit of serosa that's exposed as well, so it's less exposed to mesh. And again, this is just to try to make it so the mesh can lie flat between the stoma and the peritoneal layer. So we'll measure it one more time. We debated a lot about exactly how to create the mesh. It's a 15 by 15 centimeter mesh, and laterally I did make a sort of a half circle notch, which I removed from the lateral portion of that mesh so that the transition as the sort of bowel goes around the mesh is a little bit more gentle. One thing I certainly worry a lot about in this surgery is creating an obstruction or kinking the blood supply to the ostomy. I think an ileostomy is fairly robust. I worry more in the setting of a colostomy, but I think you have to be really careful about that. That's one of the big complications of this surgery. I think it's a good surgery in that the recurrence rates are, I think, probably lower than with other techniques, although that's not proven. But you do have to worry about the blood supply. So we've centered the mesh. You can see there's that notch laterally, so the tails of the mesh go even farther lateral. But we definitely have more than 5 centimeters of overlap of mesh from every side of the fascial closure we created. And here what I'm doing is just using a vicryl suture to kind of tack the mesh in just a few places, maybe 5 places total, just so it doesn't move while I'm completing the surgery. Again, this is not structural, but just to keep it centered as much as possible while it scars in place. And again, this should scar to muscle on the anterior side and mesentery, and on the posterior side just peritoneum, and not actually touching the bowel in this case, because we were able to just have it touch the mesentery the way we lateralized. And now the last step, I'm just using a Stratafix suture to close that peritoneum fully. We were able to make the mesh overlap that little umbilical hernia defect we encountered as well. And you can do this in a baseball stitch or a mattress fashion. And here's the final look. That was the end of the surgery. This patient did extremely well and was able to be discharged on postoperative day 1. Thanks for watching.